Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this upcoming video, Dr. Jaime Barrata from the Thomas Jefferson University in Philadelphia is going to share with us her insights into ultrasound imaging of the spine in the morbidly obese patient. If you like any of our videos, do remember to like and share them with your friends. If you're new to this channel, do remember to subscribe so that you can get regular notification of any future uploads. Now enjoy the upcoming video.
So thank you everyone for having me. As Manoj, Dr. Kamakar mentioned, I'm from Philadelphia, Pennsylvania in the US, and I'm at Thomas Jefferson University. And I'll be speaking specifically on patients, the morbidly obese patient. So I have no disclosures relative to this talk. And the objectives, really what we're going to talk about is looking for pattern of recognition in the relevant zonal anatomy in the obese patient, and talk about the benefits of spine ultrasound specifically in the obese patient, as well as some of the challenges of spine ultrasound in the obese patient. So just to show kind of where I'm from, again, you can see here that I'm from Philadelphia, Pennsylvania, not too far from New York City. So it's quite nice and early here, but not quite as early as it is in California. And these are some pictures of, where I work. It's a city hospital, it's an academic hospital, level 1 trauma center, and a very busy orthopedic and obstetric population as well. So what about obesity? The overall global prevalence of obesity has increased significantly over the past 40 years. It was really like less than 1% in the 70s, and now it's grown, to about 10% in men to 15% in women globally. Now, of course, the prevalence is greatest in the United States, but overall, there's a trend, as you can see here, all across the world. And in fact, while obesity was once associated mostly with high-income countries, the World Health Organization has found obesity increases in low and middle-income countries as well. And obese patients are frequently presenting for surgery and with comorbidities such as obstructive sleep apnea, cardiac disease, challenging airway anatomy, and general anesthesia may not be the best option. So in fact, close to half of the patients presenting for joint replacement surgery are obese, as are many of the parturients that present for surgery. So, and here again, showing, the US, we are leading, unfortunately, in obesity. And you can see here, as far as where I'm at, we're the second highest when it comes to obesity. So overall, obesity results in increased risk of technical difficulty when you're doing, especially neuraxial blocks or really any regional anesthesia on the spine. So with patients with higher BMI, they have poor back flexion, so they can't position as well as you can't palpate the bony landmarks, including the intercrystalline, the midline, the interlaminar space. And in an older study, they found that with landmark technique, obese patients had a failure rate of about 40%. And the majority of obese patients required more than one attempt, which can be, traumatic and for the patient as well as the provider doing the neuraxial technique. So in terms of palpation, there was a study in the obstetric patients where they looked at the vertebral level and found that it was correctly identified by palpation in only 55% of patients when compared to ultrasound. And in most cases, the presumed level identified by palpation was at least one level higher than the anesthesiologist thought, thus potentially setting up the patients for neurological complications. So if we're only identifying the correct space via palpation in the non-obese patient only half of the time, the likelihood of being accurate in the obese patient, where bony landmarks are rarely palpated, is very low. And there was a recent study of obese parturients with an average BMI over 40, and the authors compared landmark technique of just the transverse view and identifying midline to ultrasound. And they found that while identifying midline with ultrasound took approximately 15 seconds longer, the placement of the epidural was 2.5 minutes, faster, and the identification with the identification of midline. So they also found the number of needle passes was lower. Here was another study where they were comparing ultrasound to landmark technique. In non-obese and obese, course, was specifically going to look at the obese results. This is in parturients, and only the BMI was greater than 30 here. But they had a pre-puncture exam, so a pre-scan to identify the landmarks, and they found that the use of ultrasound, as you can see here, resulted in fewer puncture attempts, fewer levels attempted, less requiring of needle redirection, and overall the spinal procedure time was lower, as you can see where the arrows are, as well. So, ultrasound was of significant benefit compared to just the landmark technique. So I skipped past the depth, and they found that this depth was about a centimeter, roughly deeper than what the ultrasound depth was. And here, what I'm talking about is, does the measured ultrasound depth match the actual needle depth? And how does that correlate? And a number of studies have examined this concept. And as seen here, the ultrasound and needle depth overall correlate well with the ultrasound depth obviously being less. So what you're going to measure on the ultrasound is going to be less, most likely because of tissue compression. So you have to account for that. And the literature varies as far as how much compression you might have to account for. It can be a 1 centimeter or even slightly more. So it's just important when you are trying to measure the depth to the dura or the posterior complex, and as far as your neuraxial structures, to note that the ultrasound depth is not going to be completely accurate. It will be likely a different depth. As you can see here in this another study, it's a very small study of morbidly obese parturients. Well, the ultrasound pre-procedure scanning took longer. The time of placement in this situation, the number of attempts, and the total procedure time were significantly less compared to the landmark technique. And while it wasn't significant, authors did note that the palpation group required replacement, bolus of catheter, and also had an unintentional dural puncture, which none of those complications occurred in the ultrasound group. Pre-procedural imaging of the obese patients presenting for orthopedic procedures also resulted in better first attempt success rate, as you can see here. And although while the spinal procedure time was lower in the ultrasound group compared to the landmark technique, you can see here that the total procedure time involving the pre-scanning was overall longer. But the benefit of fewer needle passes and better first-time success rate is likely beneficial. But is ultrasound of greater benefit in all obese patients? And here, when the authors compared ultrasound to landmark technique in, again, this was an obese parturients, we can see they were able to, sorry about that, divide up based on BMI. So the lowest BMI 30 to less than 35 versus 35 to less than 40 to greater than 40. You can see in the lower group, there wasn't much difference in benefit as far as time to identify the structures and time taken for the spinal and total procedure time. But when you got into the higher BMI groups, there was a significant benefit. So maybe it's not that it's as beneficial for all obesity levels, but maybe the most severe obesity levels is where you're going to see the biggest difference in landmark technique. And ultrasound quality, unfortunately, when the structures are deeper, it's going to be harder to see. So this was just the abstract that we did, where you can see as the increase in body mass index, the ultrasound visibility is less. So in the obese population, it's going to be difficult to identify all the structures to differentiate between the ligamentum flavum, the posterior dura, the epidural space, as well as it's difficult to see the anterior complex and the vertebral body because it's much deeper structures. And it's all likely due to the increased attenuation as the ultrasound beam travels a greater distance. It's likely too that the attenuation is exaggerated simply because of just the irregularity of the adipose tissue, resulting in a lot of scattering of the ultrasound beam. And there's going to be a lot of reflection as well at the muscle adipose tissue interface. So not all of the ultrasound beam is going to be able to penetrate down to the structures. So all of this will degrade the image. So how I do it, it's important to remember all the different scans, and I know that was talked about in a previous talk, and I kind of change it up a little bit. I know a lot in general, most people will start with the paramedian or the sagittal views and identify the interspaces. In the obese patient, because I find I can easily get lost trying to identify the lamina because the structures can be difficult to see. I usually just kind of orient myself by finding midline, because I find that I can reliably find midline in all obese patients, while some of the other landmarks can be harder and take a little bit more time. So I try to orient myself by looking for the midline. So this would be, thinking about the transverse or the spinous process view. And just remember, with obese patients, you're going to have to adjust the depth, adjust the focus. You may need to turn the gain up. You're going to have to apply a lot of pressure with the probe. And then you're just going to look for the patterns that you're familiar with in the non-obese patients. Here, then we would move, so we look at for the spinous process and then look for the interspinous view. And at that point, I'm, marking the midline. And then I'll be looking at the paramedian sagittal oblique view and trying to find the lamina and the interspaces and identifying the different lumbar interspaces. So these images are from an older editorial, but I thought they were really nice images in an obese patient. I could see the structures very well. So this is a morbidly obese patient, was having an orthopedic procedure, and they actually were writing about how they tried to do the neuraxial technique with landmarks, and they had tried multiple times but were unsuccessful. And ultimately, they grabbed the ultrasound and they were able to identify the L3, L4 interspace via the parasagittal oblique view, which you can see there on the right side. And they were able to identify the midline by looking at the transverse interspinous view on the left-hand side. And they can even see, they point out the structures here on the left, the ligamentum flavum and the dura and the epidural space. So by getting the ultrasound out, they were able to easily get the successful intrathecal injection. So here are some scans just to show you what the images can look like in an obese patient. And of course, the dynamic images that you'll see when you're live ultrasounding are going to be, clear, and that's why practice is important. So here we have, looking at the transverse interspinous view in an obese parturient with a BMI of 44. And there we can see the shadow of the spinous process, and then, the hyperechoic lamina on the sides, and just all that dropout, because we're not going to see anything behind the spinous process. And then we move into interspinous view. So then we could see the shadow of the interspinous ligament. We could see the transverse processes out onto the side, a little bit of the articular process, and then we can start to see the posterior complex coming into view and the anterior complex, which you're not really always reliably going to see in obese patients, especially not the anterior complex, but you should be able to see some of the posterior complex in most patients from what I've found. And you could normally you could measure with calipers, but take note about the depth of the structures. And then I move into the paramedian sagittal oblique, and we can see, looking at the sacrum on L5 and L4 and interspaces. And here you could actually see the epidural space here, so ligamentum flavum and the dura. And so we can see the epidural space nicely in there, and also catch the anterior complex here as well. So we can see pretty good structures in this obese patient and get valuable information. And we could see now I've scanned up to look at the different interspaces to mark them. So we can see now L5S1, L4, L5, and L3, L4. Of course, if you ever run into problems in the obese patient, the L5S1 is going to be the largest of the spaces. And we can still probably kind of see some area that might be, signifying the different structures of the posterior complex. But again, a lot of them are going to get fairly obstructed, and a lot of them you'll see better in just dynamic scanning. And so this was the patient from the previous scans. You can see we ended up marking and our interspaces, and we went at the location of the marks, and we actually got the epidural here at this, but we ended up getting some blood back, so we moved to the next level. So that's why it's important to do more than one level, because you never know when you're going to run into problems. And we can see we have a successful epidural placement in this obese patient. Here's just comparing some different views. I thought these views were interesting because we actually found in this case, looking at this transverse interspinous view, where the BMI of 62 patient actually had better spinal sonoanatomy than the lower BMI patient. So while usually the higher BMI will account for lower image quality, in general, you're going to see that, across, really as you get higher, the image quality is going to degrade compared to a non-obese patient. But a lot of times you'll be able to see some really great images in obese patients. So it's kind of somewhat unpredictable sometimes. So you can see the structures here in the transverse, interspinous view, the articular process here, the transverse process. And you can see this hyperechoic area, which would be your posterior complex, but those aren't as clear in these other images of the BMI 41 and 45. Here's just looking at some different views with non-obese patient versus an obese patient. So we can see clearly that the obese patient has less image quality, just not as crisp when looking at the transverse spinous view, where you can see the spinous process here and the lamina and the dropout. And again, it's just due to that degradation of the image due to the obesity in the adipose. Here, the same two patients looking at BMI, again, 25 and BMI 40 on the interspinous view. Here in the non-obese patient, we can clearly see our posterior complex here and our anterior complex here and our interspinous ligament. And here we'll see, we could see on the right, we could just see the interspinous ligament and probably see the posterior complex there at the arrow, but really can't see the anterior complex. And here are the same two patients, the paramedian sagittal oblique, and you could just again see that the images of the lamina and the interspaces and the posterior complex are much clearer than in the patient with a BMI of 40. You can still see, the horse's humps up there on the right in the lamina, but you can't see any part of the anterior complex in this image, just some of the hyperechoic posterior complex. So it still gives you good information. It can get you, where your interlaminar spaces. But you're not always going to see the structures you hope to see. And again, this is that first page, that BMI of 62, and this is the situation where this morbidly obese patient, super morbidly obese patient, has much better visualization in the paramedian sagittal oblique view than the BMI of 41. So in this situation, we could see the structures very well. Here is another patient. This was an orthopedic patient, was having a total joint replacement, and his BMI was 44, and he did not have any landmarks that could be palpated at all. So we decided to get the ultrasound out to scan. So first started looking for my spinous process and my midline, and I could see here, you can see the spinous process and there the lamina. So it's kind of the swan taking flight. That kind of gave me, we were able to mark midline, then moved in to look for the interspinous view into the inner space. And we could see the shadow of the interspinous ligament. You can see the articular process there. You can see that hyperechoic area that looks to be the posterior complex, and then to the lateral, we can see the transverse processes. You can see that horizontal line, which I marked as the posterior complex, around the 7.5 or so depth marker. And then I zoomed in a little bit, so it looks like it's at a different depth. But in my paramedian sagittal oblique, and I will say I turned up the gain on this view, so on the other views I definitely could have had that's a pitfall. I just wanted to really point out that remember to adjust your gain and adjust your focus while you're imaging the obese patient, because it can help optimize your images. So here, again, I'm looking at the interspaces. I've actually scanned up from the sacrum to identify L3, L4 space, and we can see the lamina, the horse's heads, and the posterior complex there at about 7.5 centimeters. So as I like to say, it's scan first, pre-scan first, mark, and then success. In an obese patient, I don't feel there's any utility, especially for neuraxial, to do direct needle visualization under ultrasound for neuraxial. So it's really beneficial to do the pre-scan, mark, and then attempt the neuraxial technique. But it's really important to remember to be careful with the redirection, because if you kind of look at my graph, as here on the right, you can see the red line pointing, the horizontal line pointing at my target, which would be my neuraxial structures. But if you adjust your needle angle, just even the slightest, you're going to be significantly off your desired target. So it's important, you can't, to try to estimate the angle which you're imaging when you're in that interspinous view, and it'll help kind of give you an idea of the angle of how you should place your needle. But just when you're doing neuraxial on the obese patient, just make sure you're very deliberate and careful with adjustments of your needle. So a small adjustment can go a long way in an obese patient, just by the nature that the structures are so much deeper. And that's not the case in a non-obese patient. You can make a lot more adjustments and not have as much of an effect. It's also important that the skin in an obese patient can move. So it's really important to anchor the skin because it can kind of move around and you can get lost, especially off of your markings. So it's important to try to anchor with your 2 fingers is usually what I do to help kind of secure that space. This was a actually article where they talked, a case report where they talked about a patient at a BMI of 50. This was, again, patient for orthopedic surgery. So here they have their transverse interspinous view, and you could see they measured all the way down to the posterior dura there, that hyperechoic white line. They can't really distinguish any of the structures there, but they measured, and that is 8.9 centimeters. So it's probably even deeper, with the or tissue compression. So something to note that, and it can help you choose what length needle you might need in the obese patient, as opposed to struggling with a shorter needle and ultimately moving up to a longer needle. But you can see, you could still see quite a few of the structures, even in a patient with a BMI of 50. So again, it's really, really important to have pattern recognition. So this is a BMI of 41, again, a patient for orthopedic surgeon. So what view is this? It's kind of hard, again, better, see better in a dynamic view, but we could see that, our lamina are there, and we could see just a bit of that hyperechoic posterior dura. So this would be my paramedian sagittal oblique view, where I would identify some of the interspaces. So it takes practice. So practice on the non-obese, so that when you're faced with an obese patient, you can seamlessly do the ultrasound scans and have success. And I'll touch a little bit on thoracic epidural. Thoracic ultrasound has been shown to be useful to assist in the placement of thoracic epidural in obese patients, especially when landmarks are difficult to palpate. And in general, midline is fairly easy to identify with the transverse view, because even the transverse, the thoracic spine is not as deep as you'd expect in the lumbar spine. So I think the hardest area really is in the lumbar area, because those structures are so much deeper. So in general, midline is easily identified, but visualization of the interspace in the paramedian sagittal oblique can be a lot more difficult, just in general, because of the thoracic spine anatomy. But it's not impossible. There was a study where all morbidly obese patients with an average BMI of 45, they found the posterior complex was visualized in all patients via the sagittal view, and resulted in the majority receiving first attempt success with thoracic epidural placement. But it's important to note that they did demonstrate a significant difference in actual needle depth versus ultrasound measured depth. So again, pay attention to the depth. It's not going to be the same when you're using ultrasound as opposed to needle depth, because of that tissue compression. So, here you could see the spinous process and the transverse process. Here's another thoracic image, and you can see here midline and the transverse process. So I've talked a lot about achieving the optimal image, but for the obese patient, but it can be quite difficult, and serious complications can result, such as accidental dural puncture, epidural hematoma, spinal cord injury, and pneumothorax, especially when you're doing thoracic regional anesthesia. Specifically talking about paravertebrals. But these techniques are really valuable in the obese patients. We really can't abandon regional anesthesia in these patients because that can benefit the most from opioid sparing and improved analgesia. So I think it's important to think, don't get lost just because you're doing a thoracic epidural and it's not working and the ultrasound hasn't really helped you. Think about what else you can use and think about all the other tools in your toolbox. And you may have to pivot and change course when something isn't working. And as stated in, there was a recent editorial, which I state here, this the mid-transverse process to the pleura block. And they found it's a good alternative to the paravertebral block in the obese patient. So there's a number of fascial plane blocks, and I know there's going to be a really great lecture in a couple of weeks about that, and I look forward to tuning into that. So the MTP block, the rectospinal block, the retrolaminar block. So it's important to know that there's options in the anatomy, and sonal anatomy are not ideal, especially in the obese patient. We had a patient earlier in the year where we were trying to do a thoracic epidural. We were struggling. The ultrasound wasn't helpful, wasn't giving us, we could see midline, but we still weren't able to find our way in. Then we got scanned for the paravertebral space. Because of the morbid obesity, we could not visualize the pleura very clearly, so we really didn't want, and it was a GYN procedure, so we really didn't want to proceed with a paravertebral. So then we changed course and we did bilateral erector spinae catheters, and the patient did very well. So I think it's just important to remember there's options in the obese patient. So just because the first option doesn't work out, don't abandon. Keep trying and think about what else you can do, kind of in your algorithm. So here was a patient that I scanned as for a BMI of 41. So we could see our transverse processes there, the pleura, that hyperechoic area, which would be shimmering in a live view. And the star would be the midpoint between the transverse process of the pleura for that block where you could possibly inject. And it's a novel block, not a lot of literature, but it seems promising. And then here would be where you're injecting under the rectospinal muscle for the ESP block. And I would say I tend to use the ESP the most as far as all these novel fascial plane blocks. And again, it's a very easy, good alternative in the obese patient, especially. So I think it's important to leave this thought here, as it's well demonstrated in the literature that the use of ultrasound results in increased accuracy and success rate with neuraxial procedures in the obese patient. So, and this is from the Hospice Society of Hospital Medicine for hospice physicians. And lumbar punctures are different, and the anesthesiologist and neuraxial anesthesia is different. But I found this position statement by the Society of Hospital Medicine interesting. And they state when ultrasound is available with providers trained to use it, ultrasound should be used. Sorry, flip forward. Ultrasound should be used to reduce the number of attempts, especially in the obese patient or patient with difficult to palpate landmarks. So I think it's a question, should it be standard when ultrasound's available for especially neuraxial anesthesia in the obese patient? So I think it's something interesting to think about. So in summary, ultrasound of the spine can be a very useful tool in the obese patients, and it's important to practice in the non-obese patient to improve that pattern recognition. And then you'll be able to very clearly see the patterns, and it'll decrease time to do the scans. The image quality will be less in obese patients, so expect that. But you will be able to identify midline and usually most of the interspaces. It's ultrasound assisted with pre-scanning and marking is of more benefit than a direct guidance in ultrasound in their neuraxial procedures. However, obviously, paravertebral procedures, direct visual guidance is important. And beware of the common pitfalls such as skin movement, skin compression, small movements of the needle to avoid excessive angulation changes. An ultrasound may confer the most benefit of the patient with a BMI over 35. But that's just from a small study, but it just it was very interesting results. And I always say, scan and then, make sure you're marking, and then you'll have good success. So I just want to say thank you. And here's some pictures from around our campus at Jefferson. And the statue on the right is the Samuel Gross statue from the famous Gross anatomy painting, which was actually hanging in Jefferson for a very long time. So thank you. There's my contact info, and I look forward to the Q&A.